I'm going to give you guys a new experience. I went on YouTube and I was looking up ways to utilize a GoPro. GoPros have been utilized in extreme sports, so you can watch videos of the first-person narrative of riding down a cliff, of jumping out of a plane, but I didn't find any regarding presentations. So I'm hoping to upload the first-person narrative of a pain presentation. This video will be uploaded on forwardthinkingpt.com as well as nextgenpt.com so that you guys can experience the conference a little bit differently. You'll see it from my eyes versus your eyes. Throughout my discussion today, I want to interact with you guys, okay? I don't like to just stand up here and talk. I like to talk with you. So if you have any questions, please yell them out throughout my talk. If you want clarification, please yell them out. I did, when I put this together, put my Twitter handle as well as the hashtag, but I saw how many tweets were going out and how complicated it would be to try to follow all of those. So please, if you do have a question, if you want clarification, please yell out. So I want to start this discussion about Alice. A couple years ago, I was doing some consulting work for a law firm. This law firm covered auto accidents. They defended individuals who were injured on the job site. In exchange for Steeler tickets and nice dinners, I would take a look at some cases and provide expert testimony at depositions and arbitration hearings. So what happened to Alice? So Alice was a nursing student in downtown Pittsburgh. Downtown Pittsburgh is very challenging to navigate because there's a lot of one-way streets. There's not many crosswalks, things aren't labeled very well, and there's a lot of tunnels. So Alice was crossing the street to get to her next class. Out of a tunnel comes a Port Authority bus, and it turns right on a red light. That Port Authority bus struck Alice. And what you see next is very fascinating. So the law firm asked me to come to this hearing and watch this video and provide some testimony. So what I see on the video, and there's actually two videos. There's one from a camera mounted outside of the university, and there's actually a camera mounted on the front of the bus to be used in these types of hearings. The bus struck Alice. Alice was underneath a tire. Alice crawled out from underneath that tire. She ran to a sidewalk, and she collapsed. Now, one of the questions that I was asked is, she was hit by a bus. She was badly injured. How was she able to get out from underneath a tire and run to the sidewalk? She must be faking it, right? So some things that were brought up during this hearing. There were different individuals who gave some testimony. Her case manager said, I'm not sure I really believe her story. She's been inconsistent with the way that she's told it to me. The lawyer for the Port Authority bus company said, she's not injured. You saw the video. She got out from underneath the bus and she ran. She collapsed when she realized what she could make off of this injury. An IME doctor involved, not the initial doctor, but the IME doctor. If you guys aren't familiar with what they do, it's when somebody's been on workers' compensation for a long period of time, or if they've been getting health care benefits from an auto accident for a long period of time, you'll be sent to this doctor, and they'll kind of examine the entire case and generally rule in favor of the insurance company. So the doctor takes a look at her reports and says, yes, she was injured. Okay, there were some physical damages when she went to the hospital, but those injuries have healed. She no longer hurts. She no longer has any injuries. We don't need to compensate her. Very interesting testimony, and we have to imagine Alice is sitting in the audience like you guys are, listening to all this. And by the way, Alice still hurt. I know this is a pretty busy slide, but I didn't want to exclude anything from my interaction with her. So after I was brought into the case and gave some testimony, and you guys all know the neuromatrix, and I tried to explain that, and I was eventually referred this patient to my clinic. Okay. What she tells me when she comes in is, I'm not getting any better. No one believes me. You were at the hearing. You heard what my case manager said. You heard what the lawyer said. You heard what the doctor said. Why doesn't anybody believe me? I still hurt. She had a progression of her low back and sacral pain. And again, she did sustain injuries following this accident. But according to the IME doctor, everything healed. She came into my clinic and wasn't very motivated to attempt physical therapy again. Okay, initially following the accident, she was sent to a therapist, and they did a bunch of things with her, and it didn't help. Okay, so what can I do for her, because I've already been to that type of service? Functionally, this patient is no longer jogging, and she's actually considering leaving the nursing profession that she hasn't even begun, because she doesn't think that she'll be able to continue with that type of job because of this pain. She was a couple months away from graduation at this point. So what do we do? How do we explain that initial accident? And how do we take her at this point, when nobody else has believed her, and motivate her that we can get you better? We're going to do some things that are different. The strategy had to be different. Now, why is this story important? Well, everybody has a story, right? Every patient comes into our clinic and they have a similar type of story. and by the way, Alice, she did recover to an extent. She ended up moving away from my facility, and I referred her down to somewhere in the Carolinas, but she did do much better. But how do we take that patient's narrative and influence change? Pain science is gaining ground. Obviously, you guys are all here because of pain science and some of the fantastic work that Dr. Mosley has done in terms of getting this to the mainstream clinician. Okay, I would love to see these numbers for this conference grow exponentially next year. And I think that that's going to happen because the word is getting out. You guys have done a fantastic job tweeting all this out, and I think that we're starting to build a little bit of buzz about what's happening here. Now, even though we're understanding pain science, I think that a lot of clinicians, when they hear the term pain science, they simply attribute that to therapeutic neuroscience education, right? So they think that, oh, you know, this pain, it's all in their mind, let's just educate them or talk them out of that pain. Well, it's a little bit more complex than that. So when we begin to understand what do we do with these clients or what do we do with these patients, we need to understand that it's not just educating the patient. There's a lot of different variables for what we do. We want to not only affect their pain, but affect how they move. A lot of the discussions this weekend are about how to affect the pain. I loved Corey's last presentation. I don't know where Corey is, but he's wanting the patients to move a little bit better. And I think that this algorithm that I'm going to share with you guys can precede some of the stuff that Corey's doing. So when the question came about, I think it was from Eric, about some of these patients, you know, if they're not ready for this or if they don't have the expectation, this is what they need, I would follow the algorithm I'm going to present. So we term this the M.I.P algorithm. This was developed by myself as well as Dr. Francois Brzezinski. He's out of Charlotte. This was originally developed in a car, okay? So we're driving back from the 2012 AAOMPT conference in Cincinnati, Ohio. And we were simply talking, what do we do, okay? What do we do as clinicians, and what potentially helps our patients? Well, we think there are 3 things that go into place before we tell a patient to move. So a patient comes into me, Alice comes in following that accident. I'm not going to start with contractions of the TA. I'm going to interact with her first and get some other things in place before I help her move. So as we move towards the algorithm, a couple terms I want to delineate here. Movement is simply moving from, or simply the act of changing physical position. It's going from one place to another. I'm going to be using these terms a little bit interchangeably, but again, do want to delineate them here. Motor control is the generation and coordination of movement patterns to produce function. So it's all of the fancy stuff that goes into place for movement to occur. So why do we move? In Alice's case, we saw that she moved for survival, right? She got out from underneath that bus tire, she went to that sidewalk, and she collapsed. But we move for a lot of different reasons. We move to interact with others. We move for exercise. We move for enjoyment. There's a lot of things that come into play when we move. I want to get across the point today that movement is beautifully expressive and is psychosocially driven. Movement and motor control is so much more than muscles and bones. When I was in physical therapy school, I was taught how to perform certain exercises and to make sure the patient was positioned a certain way. And as Corey showed with those clamshells on the side, I was taught to stabilize the back and pelvis a certain way and have them abduct their hip a certain way. Why do we do that? Why do we restrict that? Because movement, at least in the human experience, doesn't work that way. Why do we focus so much time on the muscles when there's so much other stuff going on? So I have a video here of Tony Ingram, and if you guys follow Tony Ingram, he's a blogger as well, and a professional breakdancer, and he's working on his PhD in Canada. And I want to compare how Tony moves compared to Osimo. Osimo is probably the most humanistic robot out there, developed by Honda. Now, Osimo has all of the joints of the human body. But what's different? I can feel Tony's passion. I don't feel Osimo's passion. There is something different, guys. So what is it? Will a robot ever move like Tony? We also move differently upon social context, right? We all know how to walk. We all know how to dance, some of us. Why do we move differently when we go to a haunted house? Okay, they're not just walking, right? Why are they moving differently? Well, we can move differently because of fear and emotion. We avoid doing things because we have a fear that it potentially could hurt us. These guys are walking in fear in knowledge that these are actors jumping out at them. But something's happening to make them move different, right? So what does this mean clinically? I'm terming this the haunted house effect, okay? So clinically, what type of environment do you create your patients to move? Do you have a bunch of things that look scary? I would hope not, but some clinics do, right? Some clinics have equipment back from the 80s and 90s, and what the hell is this stuff? This is really, really important, guys. And notice, even though I'm phrasing this as a haunted house effect, there's no TM next to it, so you guys can use it. I had recently read an article about text neck, TM, right? So there was an article out that if you look at your phone too long, you're going to develop neck pain. Well, somebody came along and trademarked that, so if you use that term, you have to reference the individual who trademarked it. So again, as clinicians, what do we do? So a patient comes in, they're experiencing pain, they want to dance again. Why the hell do we lay them on their back and have them tighten up their abs? Does that translate into anything, guys? Movement involves biological, psychological, and social factors. Simply expecting pain can alter stabilizing muscle activation. Hodges done some fantastic work, okay, a while back, and kind of this idea of core stabilization came about from that. But why? I don't think Hodges said for you to lay on your back and start, feeling that TA tighten up and feel that really stabilize your spine. I don't think that was the intention. I think he made the observation that things change when you experience pain or when you expect pain to occur. Before I move on to the algorithm, I just want to share this because it was a very fascinating article from 2009, and I think it fits well within this conference. So what if no limb exists? How do you move that phantom limb? Some individuals report moving the phantom limb easily while others cannot. Okay, so how do some move it easily and others don't? Well, those who experience phantom limb pain supposedly can't imagine themselves moving that limb the same. Okay, so they have these altered perceptions of movement when they experience the phantom limb pain. Very interesting connection and very fascinating article. 3 questions that we had for ourselves when we were developing this algorithm. Does pain alter movement? Okay, we think it does, right? So if I experience pain, I move a little bit differently. Does movement cause pain? So if I have a fractured foot and I try to step on it or move a certain way, that seems to hurt. Are pain and movement concurrent separate events? I don't know. So we suspect all 3 of these potentially could be true to an extent. So the M.I.P algorithm, M stands for motivation, I stands for input, P stands for plan. This is a very broad, clinically applicable algorithm that you could utilize for helping your patients move. Motivation, input, plan. Let's talk about motivation. This is a very broad term used in this algorithm. This encapsulates the psychological realm of the individual. Motivation, by definition, is termed giving a reason to act, or the act of giving somebody a reason or incentive to do something. Okay? We could have used expectations, alliance, we could have used a lot of different things, but we chose motivation, and I'll get to why in just a minute. So will a patient move if they don't expect they can? A 2006 study looked at a bunch of individuals who submitted workers' compensation claims. And what they found is individuals who had ongoing disability were those that had low expectations for recovery and the fears that work would cause more injury or pain. This is very fascinating, and I find the workers' compensation field to be very fascinating as well because the patient comes in potentially motivated that you can get them better, but potentially with the mindset that my doctor told me to go here, I have to go see you. I don't think you're going to help me, but I have to see you. So what do we do with that individual? Well, we have to set the expectation and the stage that we can help them. We have to motivate them that something's going to change before we just give them an exercise. That individual, we don't want to lay on their back and teach them to contract their TA, right? We're going to attempt our best to allow them to know that we can help you. We're going to help you get better. And we need to validate that they're in the right place. Motivating our patients should create this desire to move and this willingness to move again. We don't want them to be fearful of moving, and we have to take into account this haunted house effect. We potentially could scare them when we're explaining what we expect them to do, right? We need to put ourselves in our patients' shoes and understand that a lot of patients that come into our doors are fearful. They haven't experienced pain before, or if they've experienced pain before, it wasn't as bad as it is now. We need to recreate that desire to move. So why did we choose the term motivation? So this is a patient of mine. He allowed me to share this video with you guys. We're going to name him Bob. About 10 seconds ago, I asked Bob to stand up. We could watch this for a couple minutes because that's how long it takes for him to stand up. Bob has Parkinson's disease. And Parkinson's disease is characterized by this general slowing of movement, right? And this slowing and decreased ability to motor plan. We know that the neurotransmitter dopamine, okay, it plays this integral role in motivation. It permits, okay, it looks like Bob's going to stand here. So that's how long it took for him to stand. Very fascinating, right? But it permits this initiation and perseverance to obtain. But what happens when dopamine's affected? Okay? Well, we see what happens. Okay, movement's a little bit different. Motivation is this term that we're broadly using. Again, you can use expectation as that algorithm. You can use therapeutic alliance. It simply is this psychological a term that we want you to think about when you're first starting with your patients. So motivation is that first term. Let's move on to input. Obviously, we know different inputs go into the neuromatrix, creating an output, right? So what do we try to do as manual therapists? Well, we try to affect an input so that you get a different desired output. We put our hands on our patients. We might manipulate the spine. We might push into muscles or trigger points or something to get a different output. Now, there's 4 different types of inputs that we want you to consider with your patients when utilizing this algorithm. There's proprioceptive input. Okay, this is the information that you're getting from the joints, the muscles, tendons, skin, all that kind of stuff. There's interoceptive and exteroceptive input. Interoceptive input is that input you're getting from nociception. I know that Diane will be talking a little bit about interoceptive input. We get exteroceptive input. So again, if we're thinking about all these different types of input, as manual therapists, we have to consider that. Because again, we deliver interoceptive input, but what are the other 5 senses telling us? What does the clinic look like? How do you approach the patient? What do you say to the patient? What music's in the background? What's happening? Okay, so we have to take into account all that input matters. All that input can create a different output. The 4th type of input is cognition, the patient's knowledge, their memory. Alice said, I've been to physical therapy before. It didn't help me. That in and of itself is an input. So again, this input plus neuromatrix creates these altered outputs. Now, what's confusing, and the fractal-like nature of this, is that any output can immediately become a new input into the system. So an output occurs, and you move differently or experience pain, and that becomes a new input, which almost creates this fractal-like experience for the individual. So how do we change that? And by the way, my wife in the back, Kristen, and my son, Asher, have come to see me, so they're joining in. He's seeing me talk for the first time. So let's think about all the input that we give our patients, right? So we put our hands on them, but I want you to look at this picture right here, okay? I absolutely hate this picture, but if you type in physical therapy on the internet, this is the first one that comes up, and it comes up in multiple ways. But take a look in the background here. So this guy is stretching this leg, which to me doesn't feel good because I just don't think that feels good. But look at that guy hanging from the bar, okay? Have you ever noticed that? Is that what physical therapy is? So think about all this different input, and think about if this guy looks over and he sees this guy hanging from the bar, oh God, I'm next. So when we break down input, I like to break it down and think about this clinically, and I think that there's clinician-directed input and non-clinician-directed input. So there's all these different things that happen from my interaction with the patient, and all these different things that happen outside of my one-on-one interaction with the patient. Again, I found this picture on the internet. I'm sorry if this is anybody's clinic. This is actually our fellowship program, so I use that just to be safe. But look what's happening here. This therapist is twisting this patient in half, and this patient is watching. What if she's thinking, I've had that done to me, and that does not feel good. That's going to be me next. So we have to take that into account, guys, right? Is the desired effect of our therapy this? So potentially she could leave hurting more than when she came in, not because of the input that I provided from my hands, but simply that exteroceptive input that she got from her eyes. When I use the term clinician-directed input, think about all those different things that I convey to the patient, right? I put my hands on a patient to try to affect change. I try to convey a certain level of confidence. I know what I'm talking about. I have 19 letters after my name. So we try to do things to create that placebo response, right? Or the non-specific effects. We try to do something to influence that outcome. The words we use, I know that John Ware, if he's here, shared Sebastian's, I forget what they're called, nasty words or something, words that we shouldn't use, but think about the way that we influence with the words that we use. And think about our appearance, okay? I know that I'm a little bit goofy with this GoPro on my head, but how do we convey ourselves to our patients? I believe that Dr. Mosley had spoke about wearing a tie versus not wearing a tie, okay? There's this esteem that's built around your appearance. And one question I want to pose to the audience here before we move on, I have about 11 minutes left. And I want you to think about this, because I think this is really important. And I've participated in my fair share of RCTs, but are they truly generalizable to your practice? If your clinician-directed input varies from that of the examiner or researcher, and I know there's statistical methods in attempting to control for this, but if I'm reading a manual therapy article, okay, and it doesn't take into account clinical equipoise or some other variables that potentially could affect the outcomes of that article, are they truly generalizable to my practice if I interact differently with my clinician-directed input? I like this phrase. I know that several individuals this weekend have spoke about Jeffrey Maitland. If you guys aren't familiar with who Jeffrey Maitland is, he's a physical therapist from Australia who really got us to the forefront in terms of manual therapy within our profession. I love this phrase, especially when we talk about the words that we use. He says to speak or write in wrong terms means to think in wrong terms. So if my patient comes in and their back hurts and I get out the spine model, and I know that I shouldn't be showing them that spine model, but I think that that's going to help them. Is speaking in wrong terms mean that I really don't get it yet? This is not a necessary slide, but are there any physicians out there? Any surgeons? Anybody? No? Okay. So I'm going to pick on surgeons here. So following a... And again, I think surgeons do great work, okay? But the research behind spinal surgery is not very good. Following a spinal fusion, the return to work probability is about 50%, okay? I don't know if you guys knew that, but very interesting statistic. And in this study, 1 out of 10 people, so 1 out of 10% of those 50%, were able to return to their normal duty job. Are spinal fusions improving function? Is this the input they need, okay? Not to pick on surgeons anymore, but does their education help? So when they talk to patients and they educate them, this is a procedure I'm going to use, is this going to help them? Well, there's evidence by not Lau yet, by Donald and Johansson that the outcomes from biomedical education does not influence outcomes. Lau this past year actually found the opposite, that biosocial education by therapeutic neuroscience education actually helped the surgical experience, and these individuals who got this education utilized 45% less healthcare expenditure. Really important piece, because as we're looking at changes in healthcare in the United States, numbers like this are important. If we can reduce costs and show the effectiveness of what we do, that's very important. And again, one more slide. Again, I don't want to pick on surgeons, but what are they educating their patients on? So some work by Lau and Butler here. About 74% of the educational sessions spent on anatomy, 11% on biomechanics, and 8% on instrumentation. So they're explaining the tools that they're using during the surgery and the implants that you're going to receive. Patients in this article got little education on why they hurt. So what does the patient conceptualize when I tell them, I need to stabilize your spine? So think again about all of this input. So I talked about clinician-directed input. So what about non-clinician-directed input? What else is happening? Think about the sounds in your clinic or the light in the clinic. Joe Nigis has a fantastic table in one of his articles on central sensitization. I believe it's table 2, but I forget the reference, where he talks about all the things that we could manipulate for these individuals in central sensitization. Lighting is one of them, okay? So if we put a patient on their back, they're centrally sensitized, they hurt, why do we have them staring up at fluorescent lights? Okay? That input could influence that output. And again, I showed you the picture of that girl looking at the other girl being twisted in half and potential grimacing. That grimacing of that patient can be an output. So what I'm recommending to optimize the noise to meet the patient's needs. Some patients simply need you to address more variables than others. And we need to understand that all these different inputs are variables into this equation. it's not just about our hands. Okay, I spent a lot of money on manual therapy education. I went through a Maitland track and got a COMT, and I wasn't content, so I went through a fellowship track and spent a couple years doing that. And what I realized in all of that is that it's not just about our hands, guys. It's about our interactions. It's about the multiple variables that come into play that affect that output. We simply need to understand that they all exist. With 5 minutes left, I'm going to try to explain the most complicated portion of this algorithm. And it is plan. And this is one that I attempt to conceptualize myself. I think that Lorimer's camp, Body and Mind, is doing some fantastic work in this realm. But is a cortical plan in place before I have that patient move? So if I pick on Karen here, and if I tell her to lay on her back and I want her to abduct her hip while trying to maintain a little bit of external rotation, can she conceptualize that? And if she can't conceptualize that, do I tell another colleague, well, she's a motor moron, I don't want to work with her anymore, let's pass her off onto the PTA, right? But maybe that cortical plan isn't in place. We have to understand this. With the getting to the edge, as Corey was talking about, does the patient understand and can they formulate the plan to actually get there? And if they can't, how do we help them get there? I know that for one of the answers that he gave, he had talked about graded motor imagery. I think that that's a great idea in trying to restructure portions of the brain that can help him formulate these motor plans. So if a patient is motivated to move, they've gotten the right input, but they can't execute that movement, what gives? Again, it comes down to that plan. Just because of time, I'm going to pass a couple slides here, guys. I think that graded motor imagery really is something that you can utilize for these patients. Have your patient close their eyes. Can you imagine what I'm telling you to do? Or simply ask them, do you know what I'm talking about? Do you know what I'm asking you to demonstrate for me? So does this stuff work? Well, I think that there is some preliminary evidence. Again, I love how Lorimer posts all these open access articles on his website. But clinically, are we seeing effects from this? I'm going to share a video with you guys of a patient of mine. He allowed me to share this video. This patient had CRPS type 2. He had, and again, let's talk about the whole algorithm. He had attempted to commit suicide, okay? He did something to himself. He laid himself in a bathtub. His arm was draped over the side of the bathtub and compressed his brachial plexus, damaging his radial nerve, creating Saturday night palsy. This patient comes in my clinic. This is after he was in a psych hospital in Pittsburgh for a little while. He presented to my clinic because I market that I'll take these guys. And when he comes in, he's not really motivated to talk about anything. He really doesn't think anything's going to help him. He's still, very depressed and a lot of variables going on. But then he asked me, have you ever listened to Ween? And I don't know if there's any indie music fans out there, but Ween is like this small, weird indie rock band, I believe from Philadelphia. And I said, I kind of know who they are. He said, do you mind if I listen to them when I'm here? Sure, because that's the input he needed, right? And when I validated and said, hey, you can listen to them while you do this stuff, it's what he needed. He was motivated and he believed he was in the right place. This is that patient. You're going to see two videos. You're going to see him prior to any GMI. CRPS, if you can't tell, it's actually his left hand. So you see how, and he's going to show you he has good active motion in that right arm. Okay, so I'm asking him to flex his left arm here. So he's demonstrating the movement that he has. So as a manual therapist, you couldn't touch his arm at this point. Everything hurt, including wearing a sweatshirt, which I asked, why do you wear a sweatshirt then? I don't know. This is 1 week after GMI, guys, okay? And mirrored active assisted movement, I'll explain that in a minute. So when we talk about the plan, is the plan important? His movement might not be great, okay? So if you're looking at it from a biomechanical perspective, you can say, well, he's hiking up his shoulder. He's doing these different compensatory movements. But he's moving, right? And this is after he utilized, I believe it was recognized for the upper extremity. Here's after 4 weeks of a GMI protocol. So this is why the planning is important, guys. We didn't take him to the gym and put him on TheraBand. Okay? I said to him, this might sound crazy to you, but let's try this. There's some evidence behind this, and I think it's going to help you. When he was motivated and he listened to wean, he started moving. So guys, that's motivation, input, and plan. Thank you. Me too.
So, we have Mandy with the microphone. I'd like to raise your hand if you have questions that you'd like to ask. If you have not asked questions before, I am going to give some context. So, no offense to anyone here. But can I see some hands? All right, I'm going to start right here. You guys asked a question before.
Hi, Joe. Excellent talk. Can you speak to the motivation part, especially in the context of that last patient?
Sure.
Specifically, maybe like what you did, what you didn't have to do, and maybe some of the more difficult cases where there's some more work that needs to be done there.
Sure. I think that the biggest thing that you have to do is self-validate that patient that they've made the right decision to come to see you, right? So simply, and I told Eric last night, this is a very strong statement when you tell a patient, you've made the right choice. Okay, when you self-validate that they've made the right choice to come see you. And for this patient, he was very challenging at first to get to open up, especially about his experience. I knew why he was there because the referral said why he was there. But talking to that patient, when I was able to connect with him regarding wean, okay, that this odd indie rock band, I learned a little bit more about wean, so that I could discuss it with him next time. Again, this might not truly influence other variables, but allows him to trust me as a clinician that I care about his recovery. So that's how I would answer that.
I have a question.
Sure, Jason.
So, you mentioned that you didn't just take him up to the gym and put him on TheraBand.
Exactly.
Would you, at some point? How do you integrate this into transitioning into more of a strengthening protocol?
Sure. So I think this has to be an individualized experience, right? So when he's complaining about less pain, when he thinks he's ready, let's try something. I would always attempt active motion first. So you saw in the video that he went through some active ranges. I probably wouldn't introduce other variables, especially ones he had attempted to commit suicide. So I'd probably be very cautious on how I would approach giving him maybe TheraBand or something that he could harm himself with. But at a certain point, we would, when he was ready, introduce more variables into the equation. But again, that's an individualized experience, and I would say that that's more of a gut call in the clinician. I think that we do a great job intuitively in knowing when to introduce something new to the patient. So when he started moving through an active range and said, you know what, I'm ready, the first thing I actually started doing with him was tossing him a balloon. So I would look at his ability to coordinate that motor plan, but in a very controlled fashion. So a balloon is very slow, so he's be able to coordinate the speed of that balloon and take a lot of variables into play, as well as giving a little bit of sensory feedback by having him put his hands on something. So when we did start things, that's what we started with, and then we introduced other things into the equation.
Now we had a question right up here.
Yeah.
Yeah, you're talking about like the lighting and things and sort of some of these non-specific factors that could be like these, maladaptive inputs.
Yes.
What kind of changes have you made in your clinic, or have you recommended, to other places that would make it like less biomedical or less scary, less haunted?
Sure. So I recommend getting rid of all the crap. So do we truly need, as clinicians? Again, we're not, I know there's some fitness professionals, so your job's a little bit differently than mine. But when I treat, and I recently wrote about Susan Clinton, she's not here, but she's a clinician in Pittsburgh as well, where her clinic has a couple treatment tables and plants. And it's such a warm, inviting environment. And she achieves, again, you can term outcomes different things, but she achieves great outcomes, and our patients feel good. So I think that clinically getting rid of the junk, potentially if a patient is centrally sensitized, do we need to have the fluorescent lights in the room that we put them in on? Can we get a dimmer light, or can we get a dimmer put on those lights? So just making those small adjustments in the social atmosphere, I think, can influence their comfort being in your clinic.
We have another question in the back. Checker church. Do we have more questions queued up?
Question, because I've always thought that patient experience, how you treat them, trumps any of your knowledge base. So I'm wondering, how close do you get to patients where you share a little bit about yourself? Sure. I find that sometimes if you say, I had a child that went through this, but there's also a line you have to have where you don't cross that professional barrier.
Yeah, you're exactly right. So generally, I'm there to listen to the patient, okay? I'm there to listen and self-validate them. With this particular patient, he had a very difficult time communicating and opening up, so that's why I did connect with that music. But I generally don't share much about my personal life unless they're specifically asking for it. So I divulge information if asked, if they truly seem like they desire that information, if that's going to influence their care. But again, we need to listen to our patients, because potentially, if I'm just talking about Asher and Kristen and what I'm doing at home and what I'm doing different places, that could be that input that really, it's gnawing at them. It's annoying them. I don't want to listen to him talk anymore. So again, I divulge information if a patient asks.
We had another question way over here on this side of the room. And we're going to have questions from maybe one or two other questions. So we've got another one over here. So we've got 1 and 2, and then if we have time, we might be able to get one more in.
Thanks, Joe. It was a great talk. And again, about non-specific input, do you ever address their home environment and how they could modify that so they're not re-exciting all of these systems when they get away from your nice, soft, well-lit clinic?
You're exactly right. So how many times does a patient leave your clinic and they feel great when they leave, but then they go home and they start hurting again? And we try to, maybe they're not following their home exercise protocol, right? Wrong. So I think that there's potentially variables within the car or at home that we need to take into consideration. Patients with whiplash. When I was finishing up my fellowship training, I spent some time down in Atlanta treating. And I had a patient there who had chronic whiplash. And she would say, I feel great when I come to therapy. I've been coming to this clinic for quite a while, but I leave and I start hurting again. So we moved her clinic to the car. So let's try treating you in the context in which you were initially injured. So in this case, she was parked out in the parking lot. Let's start moving your neck out here and see what happens. And changing that context, she actually started to understand how to move within the car. And context has a lot to do with what happens when the patient goes home. And we need to take that into consideration, guys. And if we can manipulate small variables such as how they move within the car or attempting to modify variables within their home is so important.
Another question just on the other side of the projector.
Hi, Joe. Thank you very much for your presentation for both your system as well as the case examples. My question is, when you're working with your patients, do you explicitly state the separate stages of the M.I.P algorithm, or is it all running in the background of your reasoning?
Yeah, it's simply a clinical decision-making model that I utilize before taking the patient through movement activities. So I'm not going to say, all right, are you motivated? Check. Did this input work? Check. It's going to be in the back of my mind. And I don't want to say that this algorithm is truly linear, okay? And again, this is all conceptual. It's all theoretical. So I'm suspecting that that potentially input could come before motivation or plan, or I don't know how these fit together, but I know that the three are very important when treating your patients. Okay.
I think we can sneak in just one last question over here.
By the way, yoga session 7 in the morning with Neil.
If you're really hungry, it's Neil's fault.
That's right.
Oh, Joe, I was just wondering, I don't like the idea of laying down and doing a TA.
Yeah.
So I was wondering if you could address that in terms of the potential that that actually might change an input in a positive way.
Sure, it could. But I try to take function into the picture. So does this correlate into what the patient wants to do? So if the patient's a dancer, if they're a baseball player, whatever they want to do, I try to have them move within a context. And I try to, clinically what I do, I don't just do exercises, guys. I try to just teach the patient to move. And like Corey was saying, once they kind of reach that edge, you know, let's start to move a little bit past that. Let's see if we can progress that movement. So I generally don't lay them on their back and contract a TA. I would instead probably have them stand and just try to move how they want to move. And when they start to experience pain, let's try to figure out what happened there. So that's generally what I do clinically.
Joe, thank you very much.
Thanks, Jason. Thanks, guys.